Welcome to our Animal Matters seminar series. This is the monthly periodic seminar series that the Center for Animals and Public Policy puts on. We try to pick themes that are of interest to all of our Cummings community and kind of a general audience. We typically have a lot of people joining us online. All of this whole series is supported by the Elizabeth Lawrence Fund, so which you probably have seen around. That supports activities for the Cummings community that celebrate the human-animal bond. This week, the Lawrence Fund is also supporting our course in disaster animal response. So we have 18 fourth-year students and one intern that are taking that class. So we're kind of leveraging the connection to have Dr. Majoy here talking to us in the seminar. We have more class activities going on. If you're interested in any of this, anybody from the Cummings community is welcome to attend part of our class. Really excited to have Dr. Majoy with the class and then here at the seminar series today. So he's an Adjunct Assistant Professor in the Department of Clinical Sciences. And he's also one of the criticalists at Tufts Veterinary Emergency Treatment Specialties in Walpole, Mass. He's the current president of the National Association of Veterinary Emergency Medical Services and is very active in statewide efforts to teach pre-hospital care of working dogs to emergency medical providers. And if you guys are following along his adventures, they spent all weekends teaching a bunch of military teams how to care for injured canines in the field. And he's been working on doing the basic life support course for the Nero's Law and developing an advanced life support course for that eventually we'll have more first responders be able to take. He is a triple jumbo. He went to school here, he does residency here and is faculty here. So we were like in that way. If you just add a graduate degree, then he'd be a quadruple jumbo like me, but oh, he has one. So he's a quadruple, we are quadruple jumbos. So he spent most of his veterinary career as an officer in the US Army Veterinary Corps. First was on active duty for 12 years, which included 2 overseas assignments in Korea and also at the Lackland Air Force Base in San Antonio, Texas. He also was in Afghanistan in 2020 to 2021. His primary areas of interest are management of trauma and most aspects of working dog medicine. Today, he's going to discuss his experiences in Afghanistan with regards to training veterinary and human healthcare providers in the management of canine trauma and the challenges of developing a transfusion medicine program during deployment. So please welcome Dr. Majoy.
Thank you, Dr. McCobb. Everybody can hear me okay? Well, I appreciate the invite. I'm going to talk to you guys about Afghanistan. So when I was there, I was tasked to lead really the last veterinary detachment that was on ground in Afghanistan. Every year that we were in Afghanistan was a little bit weird, but that drawdown year was particularly weird because we got there. I had a team of about 13. That was 14 soldiers. It was myself and 2 other veterinarians, 2 veterinary technicians, and then a whole host of food inspectors. And once we got on ground, day 2 in Afghanistan, I was told to send home 75% of my team, but the dogs were staying. So it very, very clearly became obvious to me that we needed to figure out how to care for these dogs because we couldn't be all over Afghanistan at the same time if something happened to them. Just disclaimers, I have no financial ties to this talk, and I am not talking about official Army policy in any sort of way. The other interesting part about at least my experience in Afghanistan is where I was stationed was at Bagram Airfield. So Bagram Airfield during the war was the main military base in Afghanistan for not just the US, but all of our NATO coalition partners. And we were in a building that was attached to the major trauma hospital, so the Craig Joint Theater Hospital. We had a pretty reasonable clinic, and every day that we went in, this is what we saw. So we saw this wall called the Hall of Heroes, and it was actually 3 walls. So it was basically the hallway entering our clinic. And all of these pictures are military working dogs that were treated during the Afghanistan war. pictured with their handlers, and each of the signs told us if they were killed in action or if they were just wounded in action. And it also told the fate of the handler. So oftentimes the working dog handler and the dog was injured at the same time. So this is what we came into every day. So it was a very sobering reminder of what we were there for, and we needed to be reasonably good at our job. So in those first couple of days, when I was told that I had a team of 4, choose carefully, I kind of felt the pressure and understood that this was going to be a very, very challenging thing. In order to understand how medicine works in a theater like Afghanistan or Iraq, in the types of wars they were fighting from basically 2001 to 2021, you have to understand what the roles or levels of care are in a theater like Afghanistan or Iraq. So the Army likes to break everything up into acronyms and name things and categorize. So we were categorizing our roles of care from role 1 to role 4. And what role 1 is, that's battlefield care. So this is point of injury, pre-hospital care, where you are on a mission with that working dog, or if you're not attached to dogs, you're on some sort of mission. Somebody gets injured, blast injury, or gets shot and needs life-saving care right there. So when we talk about role 1, that's what that is. When we're talking about role 2 care, that is when we take that injured person or military working dog and bring them to a forward operating base that has a small medical team that can do life-saving surgical interventions and give blood. So for example, if we had a military working dog that was shot in the abdomen and had a splenic rupture, they would be treated in the role 1 capabilities in the field to stop the bleeding, and then they would be moved to that role 2 hospital, and that role 2 hospital would give a transfusion or 2 or 3, depending on what was needed, and would do abdominal surgery to remove that spleen. Role 3 is where I was stationed. So we did all of the role 2 capabilities that a forward operating clinic could do, but we also had additional skill levels and equipment. So we could do a CT scan. So we could do a trauma CT scan on our working dogs. We could do MRIs. I had a human cardiology team at my disposal. So if I needed to do an echo, we could go and work together on that. And we could hospitalize for longer periods of time. So if I had a dog that had a slow recovery or needed a lot of care right after their injury and surgery, they would be flown to us and we would care for them for whatever time period was necessary. Role 4 is strategic evacuation out of a war zone. So this is when either soldiers or working dogs are flown either to Germany or to the United States at places like Brooke Army Medical Center in San Antonio, or the Lackland Air Force Base, where we have our big military working dog center, or Walter Reed Medical Center outside of DC. So that's how roles of care are established. And this is important because when you think of the problem that I had, in that I had me and 3 other people to take care of 600 working dogs, you have to figure out what roles and what levels do you train people at. Because we're going to be training veterinarians or veterinary technicians, you're going to be training other people. The next couple of slides, just forewarning, there's going to be a picture of a critically injured soldier. So if that bothers you, I want to give you the chance to leave the room. I'll pause for 10 seconds. But I can tell you about this case. So this is a 24-year-old Marine soldier that was shot on mission. And so this is the mission map that you see on the right-hand side. So number 1 is the objective. So they were out on an assault target in the mountains in winter at night. And this particular Marine was shot twice in the chest by a high caliber, so 7.62 millimeter rounds. Is this a lethal injury? Under these circumstances, do you think this is a lethal injury? Do you think this patient made it? So nowhere near care, winter, mountains, at night, all right? Do you think he made it? Let's find out. So This is more of his injury. That's a ridiculous injury to survive, if he survived. So he had a pulmonary artery transection in the mountains at night in winter, nowhere near anybody but the enemy. And he had 2.5 liters of blood loss. So that's about 40% of his total blood volume was lost for an average 200-pound man. He was shocky, coagulopathic. He made it, all right? And the only reason that he made it was combat casualty care training. So point of injury care at that role 1 level, they were able to do things fast and rapid, and they were able to care for him en route, and they were quick acting once they got to that role 2 hospital. This is one of the fortunate things that came out of 20 years of war, because if this was a case that happened in 2001 or 2002, this Marine would be dead. But you can look what happened. So on objective, so there were 20 minutes of time, this guy was shot, the Marine was shot in the chest twice. He was removed from the line of fire. He was hypotensive, so his blood pressure was 60. They placed 2 chest seals on him. They did needle decompression to resolve his pneumothorax. They got IV access rapidly. They gave him 1 gram of tranexamic acid, which I'll talk about later. They gave him some freeze-dried plasma immediately, brought him to the HLZ, so that's the evacuation zone or the helo zone, on helicopter evacuation. So this is 12 minutes to go from roll 1 to roll 2. This is what statistics look like. So he was shocky, super shocky. So his pulse rate was 180, which is way too high. His pulse oximetry was 91%. They put an IO in him, so an intraosseous catheter, and they gave him more freeze-dried plasma, and they gave him a unit of packed red cells. HPMK stands for hypothermia kit, so they warmed him up, actively warmed him while he was unconscious and bleeding to death. And that was 12 minutes. So 27 minutes, 12 minutes, that's quick to do all of these things. And then once they got him to the FOB, they put a bunch of chest tubes in him. He had an arrest, he had an immediate thoracotomy. They found the pulmonary arterial injury, so they did a trauma CT. That's how we had the image from before. They repaired that, did cardiac massage. He had return of spontaneous circulation after 4 minutes, massive transfusion, so he had another 2 units of red cells, another 2 units of plasma, and then he was moved to Bagram for recovery, where he spent some time on a ventilator, I think like 1 or 2 days. He got more blood there, but he lived. Right? That's crazy. Is that crazy to you? Like every time I've done this talk like 10 times, and every time I read this, I'm just amazed that we can fix people with these kinds of injuries out in the middle of nowhere. So you hear these stories and you get this training during pre-deployment as a veterinary team, and you're like, gosh, can we do that with dogs? So that's the problem you're trying to solve. Well, it turns out that we can, and we have early examples of this from all of our time spent in Afghanistan before we formalized any sort of training program, in 10 years essentially before I landed with my team in Afghanistan. And this is one of those examples. This is military working dog Drac. So Drac, unfortunately, was part of a mass casualty event. Drac's job, so he's a dog that does 2 things. He looks for explosives, and he's a patrol dog. So he's trained to attack people if the need arises. And this time he was out on patrol looking for improvised explosive devices at the head of a convoy in the south of Afghanistan near Kandahar. And he found the explosive, but it blew up. And it blew him up, it blew his handler up, it blew 7 other soldiers and Marines up. So mass casualty event. 8 humans, 1 canine down. And pictured here are not his handler and no veterinary personnel. So the guy holding the dog is the Afghani interpreter, and the other guy is one of the Marines who was at the back of the convoy, who was nowhere near the blast radius. So they're providing hemorrhage control, and their actions saved Drac from bleeding out at the point of injury. And once he was evacuated to the Roll 2 facility. So this is at Kandahar Air Base. So this is in the south of Afghanistan. He had a bunch of stuff done for him. So he had a trauma CT where they found a bunch of shrapnel. They fished the shrapnel out. They put a negative wound vac on him to help him heal up, stopped his bleeding. He got some blood. And in these pictures, only one out of the four of these individuals is a veterinary person. So it's the person who is right here. Right here. So this is retired Lieutenant Colonel Giles. So he's a veterinary surgeon. This is one of the human trauma surgeons. So they were doing this in the trauma bay. But everybody came together without knowing formally without a formal training program, and they helped fix this dog. And he went home. And he had a good story. So he had a good time for about 3 or 4 years after his injury. This is his handler. This is Sergeant Kenneth Fisher. And so you can see that he's missing part of his calf. And Drac ended up healing fine, and obviously was no longer a murderous, rampaging dog with the 3-year-old daughter. So we know collaboration works. And so the question when you're in situations like this is, how do you prepare? All right, how do I take my 4 people and figure out where the needs are? And provide appropriate training and make sure that we've got stuff that works in case of trauma. So kind of breaking this up into 3 tasks. For identifying teams, you have to figure out who your veterinary personnel are and are they any good at what they do? And I'll talk about that in a second. And who are your human health care providers that you can lean on and that need training? And they're going to be in different categories, right? Because not everybody's going to be at role 1. Some people are going to be at role 2, role 3. When you provide that training using doctrine that's been developed by the military and also on the civilian side, and then you have to sort out your locations. Like where are we going to provide role 2, role 3 level care? So damage control surgery, transfusions, and recovery for these dogs the way we are positioned in Afghanistan at the end of the war. And do we have equipment to do it? Does our anesthesia machines work? All right, where can we get dog blood? Like that's a big part of it, because without managing trauma without blood in theater is a no-go. You might as well euthanize every dog that comes in injured, severely injured, because they have to have blood as part of their recovery. So that was part of this puzzle that we were trying to solve when we were down in Afghanistan that last year. This is what a deployed canine care team actually looks like. They're interdisciplinary. There's multiple specialties with varying levels of experience. And as you can see here, out of the 8 personnel here, only 3 of them are veterinary personnel. So we leaned on the handler, OR techs, nurses, trauma surgeons, human anesthesiologists to help us if we had cases. But first, you have to really kind of look inwards at yourself and your team and be honest about how good or bad you are at these things, right? So before my team got split up, let me tell you a little bit more about my personnel. One of my vets was a cat behavior specialist. Okay, not necessarily helpful. One of my veterinary technicians had never placed an IV catheter. All right, and the other one worked as something else on the civilian side, so I was going as a reserve unit. So she was a horse whisperer, yeah. So she did horse training. And then there was me, and another veterinarian had some ER experience. So you look at that crew and you're like, okay, everybody's got to at least meet somewhere in the middle and level up somewhere so we know that we can manage trauma. Then the rest of my team are what we call veterinary food inspectors. So a lot of the veterinary corps mission when you go in a place like Afghanistan is to make sure that the food supply is safe. So we have folks that will inspect our commissaries every day, and they'll go to the gate when there's food deliveries just to make sure that there's been no monkey business with contaminating the food. They have 0 animal experience whatsoever, but they're part of the team that you have to keep behind, right? Because the food mission in a place like Afghanistan is so enormous. And when I'm told to go from 13 people to 4 people, I can't just kick all of the food inspectors out because I suck at food inspection, number 1. Number 2, I don't want to do it. So I ended up having to keep two of my most experienced food inspectors and another veterinarian and me. And that was who kind of ran the country for the last 7.5 months when we were there. So you just have to be, it's a quote unquote, come to Jesus moment when you're looking at your team, you're like, we're probably not going to be able to do this unless we have significant training. So in terms of training, I can tell you that the Army, the Department of Defense, has done a really good job at making trauma training available. So if you're interested in this stuff, you can Google deployed medicine and come up with the Canine TCCC guidelines. And this is what our healthcare providers did when they were downrange. We also have what are called clinical practice guidelines. The TCCC guidelines, that's for role one point of injury care type stuff, and that'll be mostly what I focus on today. The clinical practice guidelines are more for the veterinarians that go downrange and maybe the nurses and human anesthesiologists and other doctors that may help us in cases where we have to go in and do emergency surgeries. So these are all free source. You can Google joint trauma system or deployed medicine. So what did we do? Well, the first thing we did is we said, look, we need to at least ensure the people that are out with the 500 or so dogs on mission know what they're doing in case something happens. So we focused on canine TCCC training. What does that stand for? It stands for Canine Tactical Combat Casualty Care. And I'll go through that in a couple of slides more. So we went all over the country. We actually ended up training about 230 personnel or so. And this is a mixed group. So we did nurses and paramedics and MDs and other support staff, but we also looked to train our folks who we knew were going to be kind of in the fight. So our combat medics. CCAT stands for Critical Care Air Transport Team. These are the folks that fly the big C-17s or C-4s, and they can actually fly soldiers on ventilators and give transfusions. It's basically an ICU in the air. So we would train them. The PJs are pararescue jumpers. So those are the crazy Air Force men and women who will go in and extract injured soldiers from areas that most people would not think about going into. GST stands for General Surgical Team. So these are groups of about 8 individuals that are forward located. They're medical doctors, anesthesiologists that receive injured soldiers at Role 2, because they're probably going to be receiving some of our dogs if they get injured too. We also trained a lot of our NATO coalition partners. I mean, contrary to how the media covered the war, there were a lot of other countries in the fight with us there, so we partnered with them to make sure that they got the training. It was a combination of didactic and practical assessment. We made use of this mannequin called Canine Diesel, which is pictured here. This is one of our OR nurses that was located with us at Bagram doing a pressure bandage on a fake amputation. So what is it? What is Canine TCCC? Again, it's Canine Tactical Combat Casualty Care. It focuses on 3 main domains: care under fire, tactical field care, and tactical evacuation care. Care under fire, we didn't spend a lot of time with, because essentially what care under fire is you grab your casualty and you move them to a place where neither of you are going to get shot or blown up. So it's grab, if there's massive hemorrhage, cover it, and then move to cover. Tactical field care is really what we focused on with this March algorithm, which I'll talk about in a second. So that's, once you're in a safe spot, how do you prevent this casualty from dying in the next 5 minutes? How do we get them ready to be packaged up to the final phase, which is tactical evacuation care, where they can get to a Role 2 to have transfusions, damage control surgery, what have you. One of the things, if you ever get involved in this, and this doesn't just hold for military training, this also holds on the civilian side, and it's especially relevant for what we're doing with Nero's Law. And for those of you that don't know what Nero's Law is, it's a law that was passed in Massachusetts 2 years ago, where we are now legally able to do basic life support training for EMS providers in the state of Massachusetts. So anytime you're interacting with human healthcare providers, EMTs, paramedics, nurses, medical doctors, physicians, whatever, whoever you're training, try not to go straight veterinary on them and start talking about stuff we may only have. Like, don't talk about butorphanol, all right? Don't talk about carprofen or any of the things that are really things we're just going to use in a veterinary clinic, because they're not going to know what you're talking about. 2, they're not going to have any of that stuff. All right, so you should do your training with fielded equipment and drugs. So for instance, if you need to give a wounded working dog some sort of pain medication, we talk about ketamine a lot, because they're combat medics on their person have ketamine to give to injured soldiers. So we focus on things like that. One of the other things that became apparent pretty readily to me is that there's actually many more similarities than differences when we're talking about physiology and treatment for trauma. There are some differences, and what you need to do is make sure you do a good job highlighting what those differences are, because the EMTs, paramedics, or whoever you're training will get that, and that will kind of stick in their mind. And then kind of the last thing that's important is make sure you introduce these teams to an actual real working dog. I don't know how many here in the crowd have had their hands on an actual police Belgian Malinois, but if you have, you will know that they're batshit crazy. I mean, that's just how they are, and they're bred to be so driven and have this incredible energy. It's what makes them good at their job, but it is also what makes them almost impossible to handle. So you can do all of this training, but if you've never introduced a combat medic or a paramedic to an actual Malinois that's driven, once they get out in the field and are involved in their care, they're going to be shocked, and they're probably not going to be able to do too much. So here's some pictures of our training. This is on the left-hand side. This is in northern Afghanistan. That's in the Mazar Sharif NATO base. And there's a bunch of different countries here. So we've got some Dutch. I think there were some German and Australians there. This is Major Miller. She was one of the other vets that stayed with me for the duration of our deployment. And there, everybody's getting their hands on a real dog. So that's a kind of a retired Belgian Malinois that was there. So a friendlier version so they could actually do a physical exam. Right-hand side, this is at Kandahar Air Base. I am the only veterinary personnel here. I've got a dermatologist, I've got an ER doctor, I think a hand surgeon, an orthopedic surgeon, a bunch of nurses, and some support staff getting this training. So what does the training look like? I'll give you a few examples. And so some of in this particular example that I'm giving you, when we're talking about controlling massive hemorrhage, once you start discussing it, everybody that's on the human side realizes that the treatment's exactly the same. So what are your principles for controlling massive hemorrhage? And what does massive hemorrhage mean? Massive hemorrhage means exsanguinating hemorrhage, so something that you're going to bleed to death from in 3 to 4 minutes, okay? But I mean, the principles are exactly the same. You assess, use your hands, not just your eyes. Dogs are covered in fur, so sometimes those injuries are harder to find. You apply hemostatic dressings and pressure dressings for 3 minutes or more, and you continually reassess your effectiveness as you control hemostasis and you move that dog. What's different, the big difference when we do this training is that the windlass CAT-T tourniquets are the combat tourniquets that every soldier is fielded with, and that all of our police and SWAT folks also have, doesn't really work on dogs. So I have it pictured here. This is what a CAT tourniquet looks like, and it slips over your arm or it slips over your leg, and it has this winding mechanism that you twist, 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 and then lock it in place, and that's what provides hemostasis. It basically slips off of dogs that have high limb amputations because of how they're shaped. So the triangular shape, as soon as they move, they'll flip it off. So we end up using things like SWAT tees, which are basically exercise bands, and so you can get them on pretty effectively just by winding it around the dog's limb and tying it off, and it's going to stay in place. Hemostatic dressings are also, the application is the same. So what do I mean by hemostatic dressings? I'm talking about dressings that are impregnated with something that's going to induce coagulation. So combat gauze is the usual one. It has stuff in it that's going to trigger coagulation. So you pack a wound with this primarily first. This is a cadaver model of a dog. So a femoral artery puncture, a junctional hemorrhage, so it's really hard to get a tourniquet on that. So what this medic is doing is he's opening his combat gauze. And the important thing to see here is once he starts packing, you can see how deep his fingers are in this wound. And that's one of the principles that all medics learn for even treating trauma in people, is that once you find your wound, your hand is in there providing hemostasis. So he's never kind of giving up that digital pressure in the wound. And then once he's done, he'll do an ACE wrap or an Israeli bandage or Kerlex to kind of pack that whole area off. So another thing that is really quite amazing to teach human healthcare providers is intubation. And the reason for that is simple. It's like, has anybody ever intubated a person in this room, by the way? Sometimes there's one or two. All right, cool. Not that easy. Can't really see much. And then once you start teaching intubation to anesthesiologists or paramedics, they're like, oh my God, this is the easiest thing I've ever, like the light from God comes down and just illuminates everything to them. You can see everything, and you can't do that in a person. So if you want to see a human anesthesiologist get excited about intubation, have them intubate a dog. They will not want to ever intubate a human again. But I joke a little bit, but it's a really good way to key in on learning, and they got it just like this because the principles of intubation are the same. Now they can just see stuff. All right. Surgical airways, this is a difference. So if you have a dog that's injured or has some reason for choking, whether it's a foreign body or has bad laryngeal paralysis, and you need to do a surgical airway, we train to do cricothyrotomies, and we're training that because that's what the medics are trained to do. They have these cricothyrotomy kits, and instead of doing a big cut down over the trachea and doing a tube tracheostomy, they're palpating a little membrane called the cricothyroid membrane, which is just below your larynx. You can actually feel it if you stick your head up and you go down from your larynx. There's a little tiny membrane right before where your trachea starts. They know where to find that on you, and that's where they're going to put an airway in you if you get hurt. So they already know that, so we're going to train them to do that on dogs. We do talk about tube tracheostomies, but we don't really it's more of a gee whiz for them. Like, oh, look what we do in a controlled clinical environment. Another thing that's different, and this is a really good learning moment for training human healthcare providers, is how you would do a needle decompression if you had a pneumothorax. So the needles that medics in a war zone or paramedics have here to treat people is 3¼ inches long, and it's huge. It's like a little tiny sword. It's usually 10 or 12 gauge. And what they do, if you have a pneumothorax and they're treating you in the field, they're going to take that and they're going to find your collarbone, they're going to find your clavicle, and they're going to try to palpate 2 rib spaces down, or they may just guess, and then they're stabbing you. Like they're literally just stabbing you, and they're putting that down to the hub. And the reason for that is you got about this much tissue of either muscle or fat or a combination of both to get through before you get to the apical point of where the pleural space is. That's not the case in dogs because that's not where we do needle decompressions. We do needle decompressions in the middle of the chest, the 7th to 9th intercostal space. And if you were to take a 3¼ inch needle and just jam it to the hub, you're probably going to kill that dog. You're either going to be in the hilus of the lung or some major vessel, or you'll just worsen the pneumothorax. So we teach them to use what they have, but just do it differently. So only go in about 1 inch to 1.5 inches. And then once you're in, push the catheter into the chest and remove the trocar. This is what it looks like. That's their big needle. So you can see he's only going in about 1 inch to 1.5 inches, and then once he feels like he's in the pleural space, he just slides that off. All right. Okay. We also show them what a pneumothorax looks like. This is one of our hit by car patients that survived here at Tufts. Our esteemed Dr. Rosansky is going solo on this. But you can see the breathing pattern. So this restrictive breathing pattern is pathognomonic for pleural space disease. So it's really useful to show human healthcare providers what a pneumothorax actually looks like in a dog, so they've got that sight picture. Okay. We do teach them how to place IV catheters as well and do intraosseous catheter placement, and I'm not going to go through these videos, But suffice it to say, this is the second most exciting thing to them to do because IV catheter placement in dogs apparently is way easier, especially working dogs where you can see the cephalic veins from 25 feet away. We teach them where to do intraosseous catheter placement as well, because sometimes you have to do that in trauma. If they're really, really shocky, you're probably not going to immediately be able to get a line in their cephalic or even jugular very easily. We talk about things like tranexamic acid. So this is an antifibrinolytic drug that all combat medics have on their person. It prevents clot breakdown in major trauma where there's a lot of bleeding. And so it's given in people. And we have some evidence that it works similarly in dogs. So we're just talking about that to them and giving them the dose. And they have that kind of in their arsenal to treat bad trauma as well. For treating C or circulation, our main focus is on hemostatic resuscitation. So if you have blood, give blood. And this has been the big, probably one of the two biggest shifts that's resulted in saving human lives. Early blood transfusions given to combat casualties. And we try to do the same thing with our working dog population. We do go into never giving human blood products because this is a question you will inevitably be receiving when you do this kind of training. They will either have anaphylaxis or die a horrible ARDS-like death 12 hours later. So this is some of our other training that we put in place. Again, there's not a vet or a veterinary personnel amongst these groups. This is our CCAT team. So this is the team that goes from Bagram to Kandahar to Camp Dwyer to pick up casualties and be in that flying ICU. So we talked about canine TCCC. Now canine clinical practice guidelines, theater training is really more focused on the role too. So what do you do once you receive that dog? How do you save them? It was mostly focused on how to do anesthesia correctly, how to do transfusion medicine, and how to manage trauma. There was a lot of didactic training involved in it, but there was some practical as well. So what we tried to do when we were not traveling is get the canine diesel out as much as we could. This is a mannequin that you can intubate. It has a realistic airway. It bleeds back, so you can place IV catheters. And then we tried to get our folks in to do the real thing. So Major Miller is the only veterinarian involved in this. So we would have some of our human healthcare providers scrub into surgery. If we're doing surgeries, we would have our anesthesiologists do anesthesia, have them do some of our dentals that we'd have to do downrange. And I talked about our food inspectors before about having to get them trained up. This is Sergeant Carlin Crow. She was one of our veterinary food inspectors who had no animal knowledge. And by the time her deployment tour was over, she was probably our best anesthetist. And we would do blood transfusion training. I'll talk about this in a second as well. So when it comes to this case. So I'm gonna go through 3 cases with the remaining time that I have. So day 7 into my deployment, I get a call about this working dog named Trudel. So this is the Bagram Veterinary Treatment Facility. And this is what Trudel looks like. This is what I was told on our medevac call, on our 9-line medevac call. Trudel was in Kabul, no trauma, she was collapsed. She was very tachycardic. She was icteric, reported T-billy of 15. There was actually a State Department veterinarian on site in Kabul that did the initial workup for Trudel. And she told me that this dog was severely anemic and I didn't know why. 20 mics out, so 20 kilometers out. This is what she looked like when we received her. So she came off of Black Hawk and this. And her heart rate was 190. She had super snappy pulses. So she had pulses you would expect of an anemic dog. All-time greatest picture of icterus because you've got an icteric sclera and you've got a color palette of a tennis ball to compare. And they're almost exactly the same color. So she was very, very icteric. So the concern was that she had immune-mediated hemolytic anemia, and that's actually ended up what she ended up having. You can see on her saline agglutination test, you can see these clumps of stacking red blood cells, and this is very, very typical of what happens with IMHA because of how the antibodies interact with the red cells. So we knew we needed to get Trudel blood, and this comes to kind of the other main point or main challenge we had is where are we going to get this blood? One of the things that you don't have in theater like Afghanistan or Iraq is a commercial logistical route to buy components. So you can't buy packed red cells. You can't buy fresh frozen plasma. Whatever you have, you've got to generate yourself. Thankfully, the team that we replaced had started making what we call a walking blood bank. And my third day there, we took what they did and we started getting canine volunteers in. And at this particular time, when Trudel came to us, we already had 4 units of chilled whole blood and gave that to Trudel. And Trudel actually recovered. This is Specialist Green. So this is her first experience placing catheters, doing blood transfusions, any of this stuff. She had never done any of that stuff as a vet tech on the outside before. We do talk about blood transfusion basics to everybody that's in theater. And again, never give human blood. We do talk about blood typing. We talk about cross-matching. But one of the things that's interesting to remember about canines is you can give them any canine blood, whether it's positive or negative, without a type or cross-match for about 2.5 days before they develop antibodies to their opposite type. So thankfully, all of our working dogs were typed and we were able to actually give them the correct blood type. But that's what we call the first transfusion is free adage when we're talking about working dogs that have never had blood transfusions before. We talk about chilled whole blood. Whole blood is what we prefer in trauma. There's a lot of evidence in both human and canine trauma management that whole blood is better. It improves morbidity and mortality. So our walking blood bank worked out something like this. At Bagram, I had about 30 working dogs, and 2 to 4 of those dogs would take their turn in the clinic. We'd pull them off work. We would get 2 to 4 units of blood, and we would just have it for the month. And that way, if we had traumas roll in, we were ready for it. Trudel did fine. So Trudel had 4 blood transfusions, got a bunch of immunosuppression, got some enoxaparin and clopidogrel because these dogs tend to be very hypercoagulable. And after 9 days, left our hospital and was adopted on a farm in Pennsylvania, probably about a month later. What's not pictured here is that for her 9 days in the hospital, probably 60 to 70% of the time we had a nurse, support staff, PA, OR tech pulling nursing shifts, 4-hour nursing shifts with Trudel because we only had a few people at this time. We had basically 4 people left. Okay, this is working dog Gigi. Working dog Gigi is a 10.5-year-old spayed German Shepherd. So she was near Herat, which is almost on the Iranian border when you're talking about Afghanistan. And she is what we call a lifer. So she had been in Afghanistan basically for 9 years. So as soon as she was trained, she went to Afghanistan and never left. And her handler, who was a contract handler, said, yeah, something's off with her. And her belly looks kind of big and she's not really into working. She loves to work. So she was flown from Herat to Kabul, where that State Department vet said, oh, she does have a big belly, pulled a bunch of ascites out, and then they medevaced to us the following day. And so Gigi ended up having pericardial disease. So if you can see here on the image, this is a pericardial sac filled up with fluids. When she got to us, she was lethargic, her heart rate was high, and she was in pericardial tamponade. So she was in a type of cardiogenic shock, essentially. So we did a pericardiocentesis and then started worrying about Gigi because in most cases, probably about 2/3 of the time, this ends up being hemangiosarcoma. So a tumor starts to bleed and it's a really bad disease to have there. It's really infrequent that you can do surgery to get it, and the median survival time stinks. It's like 11 days with pericardiocentesis alone. But in 25% of the cases, it's idiopathic. So it just starts to bleed and we don't know why. And you can fix that with surgery. So we were hoping for that. And that's what we got. So this is Gigi. getting her CT scan at the Craig Joint Theater facility. So this is the trauma hospital. This is the Roll 3 Human Hospital. And what's not pictured here is there is a little like circular window where you could look into the CT, and about 45 human healthcare providers were lined up, like pushing each other out of the way, trying to get a look at Gigi, the working dog, going through their CT scan. Gigi did fine. So she had nothing. There was nothing that we could find. I did a full echo, and then I didn't know we had so many cardiologists in Afghanistan, but 4 of them appeared, and they all did echoes, and nobody could find cancer. So we're like, okay, we're going to do surgery, and we're going to fix her and make her a happy dog again. So we trained not just our veterinary team, but our human healthcare provider team to do a lateral thoracotomy so we could do a pericardial window. And what do you do there? Well, you open up the chest and you look for the heart and you remove a bunch of pericardial sac. So if there is continued bleeding, it just kind of drains out and goes into the chest. You do have to be careful for the phrenic nerve. So we made sure we emphasize, do not cut the phrenic nerve. We went through the anesthesia plan pre and intra-op with our anesthesia team and also with Specialist Green, who you can't tell right now, but she mostly cried for about 3 days before this because she had never done any of this. So we went through the plan, kind of the similarities and differences, how we would do intercostal blocks. We actually let our human anesthesiologist do the blocks, and we got her in there. So we talked about the anesthesia plan, the ventilation plan. So this is during surgery. This is Specialist Green doing her first dog anesthesia, and it's in the Craig Joint Theater trauma bay where we resuscitate and fix soldiers, and she thought she was in another world. This is our human anesthesiologist who appears asleep in this picture. So going through ventilation plans, I mean, again, you're talking with the anesthesia team saying, look, these are the similarities. Here's some of the differences. Like we're not worried about one lung ventilation so much. We paralyze hardly anything. Human anesthesia teams doing a thoracotomy they paralyze everything so that they can have total control over the ventilation. But this is what our team looked like. And so you can see that it's very multidisciplinary. So OR nurse, dog handler from Uganda, Specialist Green crying on the inside, anesthesiologist, somewhere in here. Yeah, I'm looking very judgingly down at everybody as kind of the supervisor of what went down. And she did fine. So Major Miller, who is a surgical resident now, was super stoked to do lead on this. And we had help from one of our trauma surgeons. We got to use their equipment. And this is what her surgery looked like. This is what super loud. I'm just going to shut that off. But do you see how thick this pericardium is? That's not normal. So Gigi had probably had this effusion for some time. And this is us just using the harmonic scalpel to make this window. And she did well. She did well in recovery. The nice story about Gigi is this happened so early on in her deployment, and she was a contract working dog that we had to retire her, but we had some logistical challenges of getting her out of theater. So she became our mascot. She actually became the therapy dog for the hospital. So she would travel around with behavioral health, and she would be the PTSD dog, and she would help out with that and soldiers that had depression from their deployment. She was adopted by Sergeant Crow. So this is like, I think 3 days before we shipped out. So Gigi and Sergeant Crow flew home together. All right, last case. This is Working Dog Pim. Working Dog Pim is a 1.5-year-old Belgian Malinois who is brand new to Afghanistan. And again, if you've ever met a 1.5-year-old Belgian Malinois, you would know they're crazy. And he didn't want to work, which is highly unusual. And so brought in and with the story of lethargy and exercise intolerance. And if you looked at him, he had this very slightly tachypnic breathing pattern. We didn't really see all that much chest wall movement. And he was a little bit febrile. So we were worried about him having a pleural space disease, and that's exactly what he did. He had a pyothorax. So that's pus coming out of the chest. So that was worrisome, obviously. I mean, in a young dog, you don't really worry that much about cancer. You worry more about a foreign body, like a migrating grass on or even a bite wound. So we decided, yeah, we're going to fix this. So we're going to go in. The first thing we're going to do is a CT scan. And when we did the CT scan, that was very, very concerning. So this is all, oops, sorry. This is all thorax. There's the heart. This is all mass, 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 mass until the very end. So this dog, for all intents and purposes, probably had about 30% lung that was functioning. This chest was just filled with a tumor of what it looked like. So I think we proceeded with the surgery because we wanted to save Pim, but we were certainly worried that this could be lymphoma or some other weird cancer, or with hope, maybe this was just a really robust granulomatous reaction. So we reassembled the team, back in there. Okay, different handlers, but same group of people. This time we're doing a median sternotomy, different anesthesiologist. He's awake. And this is what we pulled out. So it was this granulomatous reaction to a grass-on. So if you've ever been involved in pyothoracy cases, either as a surgeon or an assistant, and you think you're going to find a grass-on, you're never going to find the grass-on, ever, ever, ever. And this was just sitting on the top of this mass. Shocking. But this is a hard surgery. So we were in there probably for about 2.5 hours. We probably left about 10% of the mass still in PIM because we could not scrape it off the diaphragm. It was adhered everywhere, but we debolted it and got most of it. This is what the surgery looked like. And so our theory was that Pim inhaled a grass-on in North Carolina during his training and then was shipped to Afghanistan and brewed himself a pyothorax by the time he landed. So this is Pim. This is right after surgery, looking at me suspiciously, then taking a nap after I gave him a bunch of fentanyl. And then approximately 17.2 hours later, he became a man-eater, a murder machine, where we had to remove him from the clinic to go sleep with the handler with his chest tube in, and periodically deploying our technicians to make sure that he was still breathing okay. And this is 29 days after a median sternotomy being filleted open to remove this mass. I'll put the volume back on here because it's kind of fun. Yeah, pretty impressive, right? This is on the airfield where the fighter squadron was. We're doing a morale event for them. And he did this 15 more times. All right, that's all I've got. Happy to take questions.
I have a question.
Yes, ma'am.
Like, when you have these things come in like, unexpectedly, and you have folks that are like trained for crisis, but they're not necessarily trained for an injured animal, are people calm, or are people like, do they escalate like they do here?
It's a little of both. I was lucky in that I picked, for the remainder of my 4 people, really just chill people who didn't get upset about a lot of things, other than Specialist Green, who was always crying. But we didn't allow her to have primary hands, first of all. But some of the other human health care providers that we would do this training for, and they would receive an injured dog, they would kind of do some dumb things, like overreaction to stuff that without talking to us. So I think it was a little of a mix, and I think a lot of that is personality driven, some of it is experience driven. But you know, they saw so much human trauma there that they were kind of hardened to the idea of blood, so that you could use that to your advantage as well. Yeah. Anything else? Anything online?
No, just a comment amazing back to when you were talking about that person who lived.
Oh, yeah, it's crazy, right? Yeah, yeah. And that's somewhat commonplace by the end of the war to have those survival outcomes. Yeah, yeah. Yes.
I'm assuming you're in a scenario like this, licensing, like people can, you know, because we have such strict rules on what that and can treat. Is that doesn't apply here, I presume, yeah. Does that make sense?
It does, yeah. So the question was, you know, thinking about how veterinary medical practice acts work, does that apply in a war zone? It still does. I mean, if a human healthcare provider team who's located where I'm not receives a dog, they're supposed to stabilize and treat, but at the same time, call me or call Major Miller so that there is at least verbal veterinary oversight for that emergency. There are certain situations where that might not be feasible, especially in like role one point of injury. It doesn't really apply out there. But once it comes to more definitive role two resuscitative care, we still are supposed to have some level of oversight of them. Yes.
Does that go both ways? Like you have a human soldier that is like
Yeah.
in front of you?
Yeah, that's a good question. So what do the vets do with human casualties? Or do we get involved and is there oversight? The answer is yes to all three. So we were part of the MassCal team at Bagram Airfield. So my job was on the team that would place chest tubes and IV catheters and IOs because I knew how to do it and like I could recognize shock. The other members of my team were on the treating the group of soldiers who were going to die. And so they would be involved in like giving a little bit of morphine or fentanyl from injuries that were not recoverable. And they would help out with mortuary services. So yeah, we were on those teams. Did we have oversight all the time? Yeah, well, I didn't have like an ER of human patients to myself. I was attached at the hip to an OR nurse. Yeah. Yes. Yeah. Yeah, it was, I mean, it's this kind of work is rewarding in ways that anything else in my career just hasn't come close to yet. So I'm still a reservist. You know, there's a chance I could deploy again, but yeah, I do miss it. Yep. Yes.
I actually have a comment from online. Thanks for giving us a glimpse of your service. Nice story about Gigi morphing into a therapy dog. I am a civilian therapy dog and one veteran.
That's great.
All right.
All right.
Thank you very much.
Thank you. Yeah.